Tell me what you think, and if you want to ask any questions, you ask me the questions.
Sir, can you please zoom it?
Zoom it. Okay?
Yes, sir.
Right.
Sir, it is the frequency volume chart, bladder diary, basically.
One more. Next.
Patient. Yes, yes. Patient voids very small amount, and functional bladder, maximum functional bladder capacity is around 70.
Look at the whole diary. Don't read it like one X-ray that you normally read slide by, frame by frame. You look at the whole thing and you give me your impression. What all are the thoughts that go through your mind when you see this diary?
Sir, actually we can see half of this.
Okay, we're scrolling it up. We're scrolling it up for you. Keep scrolling. The diary was maintained for 2 days.
Yes, sir.
Keep scrolling. Keep going. That's the end of it. Look at this diary, and then if you want to ask me any questions, you can. You want to give some comment, you give some comment.
So from this we can make out that patient's intake is around 1.5 liter per day, and it is equally spaced around 100 to 200 ml at one time. And in his voiding, there is multiple. Yeah, ma'am. He is taking more after in one day he has more after the evening hours, and on 17th.
What is the time between 1:52 and 3:30 and
around 1.5 to 2 hours there.
1 hour gap?
Yes.
At times she or he is drinking every 10-15 minutes also. If you see the chart above, see it right above on the top in the beginning. Yeah, you can see 9, 10, 10, 10,
Yes,
14,
that is
10,
after
15.
evening.
So, twice an hour also take it there. What about
and in voiding, she has frequent small voids, and there is a more component of the nocturia. After 7-8 p.m., she has a higher, almost higher, same frequency as that of the day frequency.
Is it? I don't think we'll be able to see anything from it. So we measure bladder pressure, the tension, bladder see the tension in the scale just from eyeball. We put it and see normal etc. All the situation on the table. I told you.
Yes, sir. And sir, maximum function, yes, sir.
Huh?
Maximum functional capacity is around 70 to 80 mm. She has significant nocturia component. He or she.
Have you studied voiding diaries critically? I'm sorry I disrupted your class today by putting this, but I just wanted to know whether you guys look at bladder diaries critically.
Yes, sir. Sir, I would like to know the patient's sleeping hours, sir, and what occupation he is doing.
Right. Now, the first thing to do when you have a diary like this is ask about who is the patient. Is it male or female? Madam, just rightly she said she. But
Yes,
you said he. Okay. So,
yes.
the reason why madam said she is because these sort of blood frequency and the symptoms which are suggestive of overactive bladder are more common in the female sex than in the male sex. Okay. So this is a 44-year-old lady.
Okay, sir.
She lives in Calcutta and very recently, for the last 1 month, she had some burning in the urine and terrible frequency. She was treated with antibiotics and they said she's got overactive bladder and they put her on mirabegron. She continued to have painful urination and burning, and she did not improve with all these medications. So somebody who is known to me asked me to have a look at, see this person on a consultation. So it was a phone call consultation and I just asked her a few questions and I said, I want to see this diary.
Yes.
You want to ask any questions now?
Sir, I would like to ask her sleeping hours and sleep timings and her occupation.
She has difficulty sleeping because she's getting up to pass urine. You see, look at the diary. She gets up at 1 o'clock, 2 o'clock, 3 o'clock, and then between 3 and 7, she's probably just gone to sleep, I guess. That's all. But she passes small quantity. So it's both nocturnal and diurnal frequency.
Yes, sir.
How does that help? How does that help if somebody has got both diurnal and nocturnal frequency?
Sir, we will firstly rule out if she is having a history of diabetes mellitus.
If the person is having nocturnal and daytime frequency, what does it imply?
Small bladder capacity.
Yes.
It implies a reason, or it may be a pathological reason for it.
There must be. Correct. I mean, I may be having lack of sleep, insomnia due to depression, and I'll be getting up to pass urine frequently. That is also something we need to contend with.
Yes, sir.
Yeah?
Yes, sir.
But what you observe here is consistently small volumes of urine being passed. Could there be any other reason why she's passing small quantities of urine? Go down to the end of the file, end of the sheet, yes. Have a look at this. For 2 days, this is what she has totaled.
Sir, chronic kidney disease, because her output is much lower than her input.
Chronic kidney disease. She has drunk 4 liters in 2 days and she's passed only 1.2 liters. She's passed 2 liters in 2 days. Drunk 4 liters and passed 2 liters. She has got normal renal function. She's an otherwise healthy lady. She's not yet menopausal. She has her regular periods. Could there be any other reason why she is passing small quantities? Could she be retaining urine?
Yes, sir.
Huh? You have to think, man. She could be having overflow. Not overflow. She may be having small voided volumes and retaining. PVR may be high.
Yes, sir.
Possible, isn't it? I mean, if she's got normal renal functions, she's drinking 4 liters, one would expect that at least something should come out, no? There's a huge difference here. That's the first thing. The second thing is, what are the features of overactive bladder? Clinical features of overactive bladder?
Sir, frequency, urgency, and suprapubic pain, plus or minus suprapubic pain.
Again, start again. The order is wrong. Order is wrong. And the symptomatology is wrong.
Frequency more than? What is the first symptom?
What is the cardinal symptom of overactive bladder?
Sir, urgency.
Urgency. Urgency with or without urge incontinence.
Yes.
But urgency is the prime symptom. What is the other important component of overactive bladder in any woman? Other important component. Do patients with overactive bladder have pain?
Yes.
They have pain?
No, sir.
Painless, sir.
Is it an inflammatory condition?
No, sir.
We are talking of classical overactive bladder. And one of the things is, when the patients come like this, we do a urine analysis and find out whether they have infection at all or not. Isn't it? Huh? Yeah. So, you cannot label a patient as having overactive bladder when there is evidence of infection. So, a genuine overactive bladder patient will have no pain. It's just like a BPH patient with LUTs. They may describe some suprapubic discomfort, but it's a different thing. Yeah, severe burning when I'm passing urine will not be there in patient overactive. They'll have urgency. They may have a nocturia. They'll have frequency. They know which is the location of every bathroom in the town. They will pass urine. They will wear pads. They're very protective. So you must understand that these are very classical symptoms which have been described. So history is very, very important. So to label this lady as having overactive bladder in the presence of such severe burning and painful urination is not correct. It's not correct. Therefore, if somebody does come like this, it is mandated that you have a voiding diary. It tells you that she's got a maximum bladder capacity of 110. The last one.
Yes, sir.
Okay? Which is very poor when compared to a standard woman's bladder. So she's got small or reduced functional bladder capacities. She probably is retaining urine in her bladder. Okay? She's probably retaining urine in her bladder. She's got normal renal function. Alright?
Yes, sir.
She has got pus cells in the urine. She's got pus cells in the urine and the culture is sterile. So, what are the things that you will do now? She has been treated with antibiotics. She has some relief and no.
So we'll try to rule out the causes.
She's taking Fosserol, myphos.
We'll try to rule out the causes of sterile pyruvia.
The first thing you want to do is whether she's emptying a bladder.
Check her.
You check her ultrasound. Take an ultrasound. And the ultrasound shows the residual urine volume of 80 cc. Upper tracts are good. That's all that's it. So the first thing to do is to find out whether this PVR is a consistent phenomenon. In women with recurrent urinary tract infection, a value that has been quoted by a randomized study done some years ago was that if they have a PVR of 30 ml or more, they are likely to develop recurrent UTIs. We don't take that into account because not many people have read these studies and all that. So it's okay, we pass it off. But if you look critically, you will realize that yes, not many studies have been done in that particular angle. This is one of those landmark studies which have been done. And I'm telling you this because when I was looking at this problem of recurrent urinary infection, I looked at some data and I looked and found, oh, this is only one study of its kind. It's quoted, but unfortunately not many have read it or whatever. It's like so many articles which are there in journals, you don't read everything. You don't have time to read. But this is an important figure that has been quoted there. They found that if the woman has more than 30 ml of residue, her risk of getting UTI is much higher. That aside. So this lady has got normal upper tracts, but she's got this sterile pyruvia. So you can't treat such a patient just as overactive bladder and go away. So what I'm trying to emphasize to you is the history is very important. History is very important. The voiding diary is very important. It now tells you a whole host of things. Now this lady cannot be left alone. She says she's not a diabetic, but this may be the first manifestation of diabetes.
Yes, sir.
She may have a fungal cystitis because cultures are sterile. She's got pyuria, so this may be the first manifestation of diabetes. She says she's not diabetic, I told you.
Yes, sir.
The next thing we need to do is, does she have tubercular cystitis? We have seen this, that the bladder is a sounding board for renal TB or urinary tuberculosis. Alright? So
Yes.
you can't leave this lady alone. So it is mandatory on the urologist to saw her, not to say, come back after 3 months. That is the advice that was given to her. That is wrong. You cannot tell such a woman, you come back. If you have made a diagnosis of UTI, which we see so frequently in everybody, you give them one tablet and they're all right. One sachet of Fosserol and they should be all right. And the beauty is of recurrent UTI, which is so common, is that in between episodes, they are absolutely normal. They are fine. When they get the bang, the UTI, they know they're not negative. So, that's how it is. Recurrent UTI, within 6 months, you get 2 episodes, or within a year, you get 3 episodes. Whatever. There are various definitions. But you have to be sure that you are labeling somebody as recurrent UTI bacterial, which is the usual uncomplicated type of cystitis that we see in women. 80% of women have had at least one visit to the emergency room for urinary tract infection. So it's very common. But when you have a situation like this, the history is very important. This lady could be having bladder pain syndrome.
Yes.
In bladder pain syndrome also you have pain. You have terrible frequency. You drink a lot of water so that you pass urine and because the bladder fills up and you get pain. So the history is mandatory. A very, very close history, very detailed history on this is very important. Most of the time in urology, when voiding functions, I'm not talking of RCCN, I'm talking of lower tract. And the history is very, very important. So go back to the start and find out what is wrong with such a patient and decide, is this somebody who's got an ordinary overactive bladder, you can give something. You understand? That's why I brought this diary up. Don't look at voiding diaries as though they are a piece of paper. No, they are very, very valuable. Actually, the recommendation is 3 days. But for various reasons, we say 2 days. I say 2 days simply because, patients come. I have an OPD twice a week, so I call them. That's why I say, okay, 2 full days. So she has to have urologist review wherever she is. She can't be left alone. She has to have the upper tract evaluation and not an ultrasound. She needs something that's going to tell us what's the calyx looking like, what's the ureter looking like. This could very well be the first manifestation of urinary tuberculosis. All right. She needs to have endoscopy. She needs to have cystoscopy. She needs to have urine culture. She needs to be sure. You have to be sure she's not a diabetic. Which means she must have a hemoglobin A1C and a fasting done. Not random. Many people just go and give her something and give her. No, it doesn't work. You have to be strict about it. Okay?
Sir, without RBCs present in the urine routine, can we think of renal tuberculosis if this comes as a...
You won't have huge number of RBCs. You won't have huge number of RBCs. You just have a few. But this lady has got hardly any RBCs in the urine. She never had hematuria. No macroscopic hematuria. She just got severe burning when she passed through. So don't just pass off something as, oh no, it's okay, upper story problem. No. It's genuine here. If a lady has got diurnal morning, daytime frequency, but sleeps through the whole night, the most important question you will ask her is what? If she's got a lot of frequency during the day, this type of frequency, but she sleeps through the night, what is the most important question you'll ask her in the history?
Intake in the morning.
Intake in the morning. Like this one. Say the voiding diarrhea is like this during the daytime, but she sleeps through the night. Doesn't wake up. Comfortable. What's the question you'll ask? The most important question, which is a clue. But Tarun, what's the most important question you'll ask her in such a lady? You understand the question? Hello?
Yes, sir. Hello?
You understand the question?
Yes, sir.
Yeah. Daytime she's got this type of frequency, but she sleeps through the night. No problem. Then sleeps at 10 o'clock, gets up at 7 o'clock.
Less likely to be pathological.
What is the question you'll ask her? During the daytime, she's passing like this. 100, 50, sometimes 80. Ask her what is the voided volume when she wakes up first thing in the morning.
Yes, sir.
If that voided volume is 400 or 300, which is normal, she has no business to be passing urine 50, 100 during the daytime. It obviously means there is some relationship between her demeanor. She may be stressed out. She may be drinking a lot of fluid during the daytime. Her job may be such. So you work on a different strategy. You work on a different angle. And such people may not have a lot of symptoms in terms of pain and burning. They'll have only frequency. Going to the toilet, running to the toilet, running here. So that's what it is. Okay. So you understand how you work on avoiding diarrhea. It's very, very important to look at this very critically and not just brush it off. And go back and ask questions of the lady, did you record it properly? They said it. There's one thing we have found. All the studies have also shown. No patient bluffs avoiding diarrhea. It's absolutely a truth machine. I've got a problem, no? I'm seeing somebody. I've got a problem. If I didn't have a problem, I won't go and see you. Why should I go and see you? A doctor? I have a problem, so I'm going to see you. The doctor has not told me to do this. And if my problem has to be set right, I will do it correctly. If I don't do it correctly, then I'm not interested. I don't have a problem. Why should I waste my time? What they could do is fill it up incorrectly. And this happens in younger people. if it's a younger person, usually if it's a 12-year boy or 13 boy or something like that, or a girl, the parents will usually know you didn't fill it up properly, something wrong. You can make out when it's all haphazard and irregular. So look at Paul Abraham's book. You will have some series, some voiding diaries which are showing you things like this. But I thought instead of having the regular no mass, this, that, everything, something different to stimulate your brain to think about common things which are there in urology. We see this. Okay? So this lady needs a full evaluation.
Yes, sir.
Okay.